Hi again, everyone. Here we are with the third installment of Chapter 9, dealing with pulmonary issues, where we're going to talk about rhinitis and coughing, and then just some general considerations about nonspecific chronic obstructive pulmonary disorder. I thought this graphic was really interesting. Not to belabor the idea of COVID-19, it's good to understand what the symptomology profile is for, say, just allergies, as opposed to COVID-19, or maybe a little bit of both. In some cases, you're not immune to getting them simultaneously. Keeping on top of this, because I think it is something we're going to be dealing with for a very long time in our society. So good luck, and finish off this chapter.
So we finished with asthma, at least in theory. But one aspect of asthma and one aspect of pulmonary disorders is coughing. So let's talk about coughing a little bit and how we might deal with it. So the coughing can run through a classic reflex arc, if you will, receptors that send nerves up to a center, and then that they send it out motor nerves to muscles in the intercostals and the diaphragm to create this cough. Though it can be triggered directly by irritation in areas of the pulmonary system. So how do we deal with coughing? And well, maybe what we do is suppress some of these sensory neurons, since oftentimes what coughs do is they are just a generalized response to irritation in the pulmonary system. So why not numb it up with a topical anesthetic? Coughing is like scratching an itch. It can induce additional irritation and thus additional coughing. So one of the theories for dealing with coughing is trying to break the cycle that escalates coughing. And there are mixed opinions about that because people will then argue, well, you cough because you need to cough. And by suppressing coughing, you may be prolonging the presence of irritant in the airways. And so that's the theoretical or the therapeutic considerations that somebody who's prescribing cough suppressants will have to think about. But if we use a topical anesthetic, these are available over the counter, and what you're doing is just numbing up the area so you're not sending signals either to the cough center or to the expiratory muscles. You can also inhibit the central nervous system. So opioids, in particular, a drug called dextromethorphan. If most active biomolecules in our environment are left-handed in terms of how they bend light, dextro means right. So dextromethorphan is actually a right-handed isomer of an opioid. So it's a lot less addictive, but what it's doing is it's suppressing neurons, suppressing synaptic transmission in the areas particularly associated with the cough center. So you can suppress coughs specific or relatively specifically with opioids, in particular dextromethorphan, though codeine and hydrocodone will also do these things. Let's turn our attention now to rhinitis and rhinorrhea, which is underappreciated. Certainly from an inconvenience and discomfort standpoint, that's one thing. But one thing we tend to overlook is how it can impact our daily experience in our lives. We think of taste and eating and so forth as being something on the tongue. Well, there are only 5 flavors there, but we can smell literally trillions of things in our noses. And so a major aspect of enjoyment and sensation is our sense of smell. So this can be a very inconvenient and potentially impactful loss of function when we have rhinitis and rhinorrhea. So we have inflammation of the nasal mucosa, which can extend back into the nasal sinuses. It can be acute, like in the case of a cold, or even extremely acute if somebody punches you in the nose, that sort of a thing. Or it can be more chronic, low level, again, with this idea that if you impact the nose, you're impacting all sorts of things above and beyond just what we might think of as smell. Rhinorrhea is the production of watery nasal secretions, so buildup of fluid Inflammation can lead to loss of patency of the airways, difficulty breathing, difficulty smelling. And if you have difficulty smelling, just as an example, people who can't smell or have very, very reduced smells tend to be extremely picky eaters. Just recall those times when you have a cold and a very stuffed up nose, how nothing tastes good. That's because a lot of those ancillary flavors, like for instance the perception of chocolate, or other smells like the smells of citrus and so forth, those floral things that make food very enjoyable, often go away and things taste very, very bland. Both of these are the result of inflammation. That can be because the most common thing would be viral infection or a type 1 hypersensitivity, that is IgE mediated. So if somebody has very active mast cells, we do see mast cell populations relatively high in the nose. The receptors are very, very reactionary. They will react with many number of things that may also trigger this inflammation. And inflammation everywhere involves blood flow, vascular permeability. So what we have going on here is that the blood vessels dilate in the nose, and the capillaries become leaky. So we have swelling, and we have release of fluid in those passages, which reduces what we call patency. So you have reduced airway diameters, and so you have greatly increased resistance to flow. So how are we going to deal with this? We're going to try to constrict those blood vessels. And so we do that using something like a sympathetic agonist. Trouble is, though, side effects, side effects, side effects, especially if somebody has issues in other organ systems. So things like increased blood pressure, or exacerbating diabetes because you're increasing blood sugar, or you can exacerbate their glaucoma, and certainly there's some tolerance issues, but mostly what we're dealing with are those standard sympathetic side effects. On the other side, maybe we can attack the inflammation. So we might use an antihistamine. Again, we're getting after those mast cells, or we block the receptor for histamine. Either we block the action of histamine, or we block the response to histamines. Steroids in more serious conditions, leukotriene receptor blockers have demonstrated efficacy. And in order to get around those side effects, we often deliver these things locally in order to get around the possibility. But it's still possible with misuse. It's still possible to introduce these agents into a more systemic distribution, leading to side effects. And drugs that kind of go alongside this, though, may not necessarily be specifically for rhinitis or rhinorrhea. There are other conditions, in particular cystic fibrosis, where you have mucus buildup in lower airway passages, which can lead to obstructive-like disorders, particularly if you're talking about in the epiglottal region or slightly below the epiglottal region in the trachea. And so we have what are called mucolytic drugs. They're designed to liquefy and or break down mucus. Mucus has a range of viscosities. The mucin protein is very, very hydrophilic. And so you can have very, very thin mucus way down deep. And as you get further and further up the airways, that mucus can become more desiccated. It can have higher protein concentrations, and thus become more of a sticky trapping agent. And that's where we see the buildup. If you have increased desiccation, if you have increased protein concentration, that leads to that difficult to deal with mucin. So we can deliver these things locally, nebulizer, or you can actually spray it into the trachea by an injector. Usually what we're dealing with, though, is somebody who has particularly severe situations or chronic situations that require this sort of administration. These aren't as common as it might seem. They're out there, but really for folks that are having a really hard time moving these secretions out of the airways. Homocysteine is an example of this, and again, I'm not going to get into the individual agents. Some of them are designed to activate enzymes that break down the mucin protein, hydrolytic enzymes, and so forth. So these are activating enzymes that break down mucus. Dornase alpha and acetylcysteine. They're very, very common. But again, you don't see this normally in patients that are suffering from colds or anything unless it's particularly severe. This is more along the lines for folks who have COPD, folks that can't mobilize mucin because of either damage or chronic irritation to their airways. To sort of summarize this, what's going on in patients that have these sort of issues, this is cystic fibrosis, and if you've not seen this mechanism, it's actually pretty interesting and serves as a good role model, if you will. What's happening in our pulmonary systems is we have to get water to the surface. We can secrete proteins directly, then that's great. There's issues there if you can't secrete the proteins, but those are different diseases. But in the case of cystic fibrosis, what we're trying to do is get liquid to the luminal surface. We can secrete proteins just fine. And how we do that is we actually move chloride out of the blood plasma into the epithelial cells that line the pulmonary airways. And so you bring chloride in through a secondary active transport process, and so chloride concentrations build up, and then we allow that chloride to move down its concentration gradients with these channels. The primary channel in cystic fibrosis was actually hypothesized before we discovered it, and that's why we gave it the name CFTR. So we knew there was some way of getting chloride from within these cells to the luminal surface, and it turned out to be this anion channel, CFTR. Cystic fibrosis patients lack this CFTR and therefore can't move chloride to the surface. And if you can't move chloride to the luminal surface, then you can't bring sodium along. So what we do is chloride moves here, creates an attractive environment for sodium, lots of negative charges, and so sodium will move down, and its electrochemical gradient by virtue of this electrical charge. Now sodium doesn't move through the cells, it moves between the cells. And then lastly, this buildup of ions on the surface creates an osmotic gradient, and water, so as these concentrations rise, the water will want to diffuse again outside of the cells paracellularly, and that's how we bring water to the surface, is through this indirect mechanism. And if we can't move chloride, we can't move sodium, and we can't move water, and that leads to a very, very thick and viscous situation that is life-threatening. One more thing about cystic fibrosis, and that's the idea of it being an autosomal recessive disorder. So here's our mutant CFTR over here. It doesn't move the chloride and causes mucus buildup. Certainly in the airways, but we also see issues in the gastrointestinal system. They have a number of issues. If you have a normal CFTR gene that you inherit from a parent, as well as an abnormal one, that makes you what is known as a carrier. It's autosomal recessive, so if you receive a mutant copy from one parent and a mutant copy from another, then you have the disease. And that's the sort of heartbreaking aspect of this, is that you can have two phenotypically normal parents, and then they don't know that they're carriers, and then they have children who have cystic fibrosis. Cystic fibrosis, like asthma, can be a progressive disorder if not mitigated. What you see is occlusion and then inflammation and destruction of alveolar and airway material in patients with cystic fibrosis, due to probably irritation and inability to move material out of these airways under normal mechanisms of ciliary motion, etc. So you certainly see lung problems with cystic fibrosis, but again, that CFTR actually shows up in other things like sweating and digestive tract. Our final section in this lecture today is a more generalized discussion of chronic obstructive pulmonary disorder or disease. And the most common forms of these things include asthma, chronic bronchitis, and emphysema, which we have yet to talk about. We've certainly talked a little bit about coughing and asthma before, so we're not going to go too much more into the asthma side. But again, just kind of bring this out into a more generalized discussion of the disorder of COPD. Bronchitis, just like asthma, involves chronic irritation. So if you have asthma, it tends to be a more genetic and inflammatory predisposition. With chronic bronchitis, it just seems to be a similar thing, only the etiology originates in coughing and then in irritation that may or may not have genetic components. It could be because of smoking and other things. So it's a little bit less genetic predisposed than, say, asthma is. But it's the same sort of etiology. Emphysema is more of an issue of surface area, and you very rarely see emphysema absent of bronchitis or emphysema absent of asthma. These things tend to run hand in hand, and so sometimes it can be a little tricky teasing each one out as to exactly what's going on. Emphysema in the classic sense is the loss of surface area in the alveolus. So we're going to talk about how we deal with that and how we manage. Some of the things you've already heard, but repetition and continued thinking about it in different directions is always a helpful exercise. That is somewhat analogous to what will happen in the workplace. COPD, in the classic sense of the disorder, is that chronic progressive loss of ability to move gases either through the bronchial conductive airway systems, or if we include emphysema, the ability to move gases, transport gases in and out of the blood plasma. So it's a chronic and it's obstructive, that it's hampering the ability to achieve metabolic need in terms of gas exchange. So it can be slow, even so slow that the patient may not realize that they have COPD or asthma. But it is progressive, and it will get to a point where it will manifest and it will impact occupation. Sometimes you see flare-ups. That can be due to infections, or it could be due to some other triggering additional inflammation. Folks who have COPD at any level are already somewhat compromised. It doesn't take a whole lot more. They may be able to meet metabolic need just fine if the airway is where it's at, but they're walking a fine line. It doesn't take a whole lot of inflammation, additional, shall we say, additional inflammation or secretion to lead to very, very serious debilitating conditions. The symptoms are often, abnormal breathing patterns. They may be continuing to try to expectorate material out of their airways. That sort of, kind of thing that you hear patients, particularly smokers, because the airways are narrowed, and so any sputum in there is going to potentially hamper because you've already reduced the radii of these airways. So increased resistance. Sometimes what you see is loss of the epithelial function on the surface, so getting that material out of there can be very, very difficult. That's also why we often see sort of a barrel-chested morphology in patients with COPD, because they're using their accessory muscles a lot more, and so forth. But if it gets to a point where it is a true acute situation, what we have is mismatch. You've got what we call the VQ ratio, the ventilation to perfusion. And when you get that mismatch, that's when the problems really begin, because now you have impaired gas exchange. Some forms of COPD tend to be in the conductive airways areas. So we get, and particularly asthma is this way. You may have perfectly normal alveoli, but if you can't move that air, what you see is a buildup of CO2 and a reduction of oxygen, loss of gradients here. That can cause a phenomenon known as air trapping. In the case of emphysema, and I would argue pulmonary fibrosis, but that's more restrictive, and I don't want to go there. Okay, obstructive versus restrictive. In any case, in the purely obstructive sense, what you have done you've reduced surface area back to Fick's law again. Reduced surface area means inability to exchange gases. So you may be able to move air to meet metabolic need in theory, but if you don't have the surface area, then it's much more difficult to get the pulmonary oxygen to the level that it needs to be, or to reduce pulmonary, I meant plasma oxygen, plasma CO2 out of the airways. Some signs and symptoms of COPD: exercise intolerance, certainly dyspnea, maybe a chronic cough, that barrel chest, because they're using all of their accessory muscles in addition to their diaphragmatic form of breathing. Occasionally, and this is more common in emphysema, is what they'll do is they will involuntarily try to increase the pressure of the gas. If you increase pressure, you increase concentration. So what you'll see is these people will sort of purse their lips, not realizing that what they're doing is trying to force more oxygen into the airways. There's a secondary aspect of this when you have fibrosis and stiffening of the pulmonary epithelia in the lungs. That can lead to what is known as pneumothorax. And so there's a theory that this pursed lip breathing is staving off the potential for pneumothorax. Though how you would perceive that, I don't know. Certainly you perceive blood oxygen and blood CO2 concentrations. So I think it's more along those lines. But again, you're using additional muscles, you're working harder, you have less oxygen to use for exercise. Later on, you might see things like cor pulmonale, certainly loss of body mass in severe situations, and this really, really interesting phenomenon known as digital clubbing. Lung cancer can manifest this. So this is caused by chronic low blood oxygen. And so cystic fibrosis patients manifest this quite often. And this is where, again, you guys can be really, really useful if you're with patients, is to spot these signs and symptoms. And I strongly encourage you. I strongly encourage you. Yes, we have things that we're already interested in, and there is a discipline, but the true power in healthcare is interdisciplinary thinking, and they don't get much better than this Stanford 25. A really, really beautiful TED Talk a few years ago by the professor who's sort of leading this effort, a guy named Dr. Abraham Verghese, who's actually pictured right here. He's a professor of internal medicine at Stanford, developed this. And it's absolutely magnificent. Like, for instance, the hand in diagnosis, like certain types of position, like what we call the Pope's hand, can be illustrative of certain types of neuromuscular disorders, or the clubbing in the hands, or what we call quitter's nail, which is nicotine staining. These things you can do. You don't have to be a physician to be able to see these things and bring them to people's attention, whether it's a clinician or it's actually the patient themselves. It's a strong, strong motivator to show evidence to a patient. And so I recommend you get into this. I think you guys would really benefit from it. Sorry for the digression, though, if you think it's a waste of time. And this is one of the great things that I love about pharmacology, is that it sort of builds. So we don't have to go through all of these things yet again, because we've already been through them. Now we can begin to talk real strategy, and that's the beauty of this. This scaffolded understanding can lead to better conversations, can lead to better understanding of why we would do the things that we do. And so let's just work through some of these treatment options. Certainly smoking cessation, or to eliminate the possibility of irritants in that person's environment. Whether it's occupation, whether it's location, and certainly anything that will reduce the possibility of inflammation is always the ideal situation. Or if that's not possible, or if it's not enough, we can bronchodilate, and we've talked about those. Beta 2 antagonists, those sorts of things. We can use inhaled corticosteroids to dial down inflammation and or populations of granulocytes in the airways. Pulmonary rehabilitation, we can work on exercises and breathing, so forth, in order to maximize the efficiency of ventilation. And then oxygen therapy, if they just can't get those PO2 concentrations high enough in the alveolus or in the blood. Lastly, maybe surgery in order to remove malformations, obstructions, or damaged and infected material. In terms of therapeutic concerns, since we are dealing with an organ system that is very, very involved in the sympathetic and parasympathetic systems, and now we're giving drugs to affect them, then we see those adrenergic, cholinergic side effects. Normally, when you're trying to bronchodilate in a COPD, you're going to give either an adrenergic agonist or a cholinergic antagonist, and both will contribute to tachycardia, hypertension, urinary retention, dry mouth, constipation, all those sort of pro-sympathetic responses. When it comes to corticosteroids, you're certainly mediating inflammation there, so you're dialing down cell populations, you're dialing down inflammation, but that can put things out of balance in the airways. We're always in a balance, a homeostatic balance, if you will, in terms of faunal and bacterial populations, whether it's in our pulmonary system or on our digestive tract or on the surface of our skin. So if you suppress the immune system, you may provide an opportunity for increased populations, and that can lead to infections and untoward symptoms like candidiasis, which is basically a fungal infection inside the mouth and the throat. Thrush is a little more throat-oriented, but again, that can lead to severe side complications, difficulty breathing, and so forth. The other side of corticosteroids is that you're affecting the genetic and expression and or function of cells and other tissues. So we see increased bruising in patients. You're mobilizing calcium out of the storage areas of the body, which include the bone, due to those steroid functions in the osteocytes. We already mentioned risk of infection due to the fact that you're immunosuppressing. You also have metabolic effects of corticosteroids. They can trigger a sort of sympathetic response, which means loss of glycogen, maybe reduction of fat in some cases, and that can lead to muscle and skin atrophy as you use up those fat storage areas, or you burn glycogen and now the muscle is resorting to protein for energy. So it's going to break down muscle tissue for protein. With irregular breath sounds and difficulty breathing, one of the things we want to be careful of is the idea of exercise intolerance. You want to pay special attention to situations where you're trying to increase or enhance respiratory function. You may induce inflammation accidentally if the breathing is too vigorous, or they're exposed to allergens and so forth. And so that wraps it up for Chapter 9. Again, you work in tandem with your book. Look to the areas that we discuss, read those sections that are discussing those same topics in your book. We're looking at concepts. We're not looking so much at specific agents unless I really, really say, hey, know this agent because it's a model system or something along those lines. Side effects, ADRs, potential therapeutic considerations are always sort of at the top of the list. Thanks for your time, and I will talk to you again soon.